Everyone. Hi everyone, welcome to Thursday VMR. I'm so excited to see everyone and doubly excited to discuss with Robbie today. And just before we kind of get started, putting a plug for if anybody has a case, if you'd like to share with us, that would be so much fun.
Yeah, Sukriti, we're finally coming full circle. For those of you who don't know, Sukriti was the first ever non-North American based CP Solvers team member. And she is inspiring in more ways than I think she realizes. She kind of casually emailed the CP Solvers and said, I'm just like an artist and I kind of just do a little bit of art. Let's see if we can work something out together. And then when you actually look at her work, it was mind-blowing, like absolutely mind-blowing. And so everything that you see before you related to the CP solvers, be it in the artistic domain, in the IMG domain, and in many, many others, all originates from that email and from this incredible human being. And so we've been working really, really hard to try to get Sukriti, who is a busy resident, to join us back again on VMR to commemorate many a special occasion. And it's finally happening. Super, super psyched. Are you feeling nervous, Sukriti, or how are you feeling?
Feeling super nervous.
Yeah, I know. It never goes away. It never, ever, ever goes away.
It doesn't go away.
No, unfortunately not. But hey, you know what? When you get going and you're amongst family, things smoothen out a little bit. Does anyone have a case for Sukriti today? Going once, going twice. All right, Ravi, we'll lean on you, my friend. Thank you for covertly volunteering.
All right, let me just pull up. Okay, so are we ready to rock and roll?
Let's do it.
So our case today involves a 50-year-old female, has a history of sickle cell disease and frequent vaso-occlusive crisis, who comes in with bilateral leg and shoulder pain. And during her workup, she becomes altered. And I'll stop right there.
Take it away, my friend. What do you think?
This is super interesting. So I think in terms of, I think Ravi has actually given us a lot to work with just with the chief complaint. And then kind of from what I've learned from CP Solvers and Ravi and Reza is you can see this in three parts. Ravi's told us the age of the patient. This is a 50-year-old female. The second is that he's given us some background that this patient has sickle cell disease. She has a history of frequent vaso-occlusive crisis. And then he's given us the foreground, which is essentially she comes with leg and shoulder pain. And then the fact that she becomes altered during the workup kind of clues us into the possible underlying severity of this whole syndrome, that A, she's progressing very fast, and B, this could be a clue to some underlying sinister etiology. So not only are we thinking about this case in terms of deploying our schemas, but also thinking about this case in terms of management. I've heard Reza speak about this often in the podcast. When you have a patient that's altered, you kind of go through your ABCs, and then you want to make sure that their airway, before you kind of go through the diagnostics, that their airway is intact, and those kind of things. So I guess those are my initial thoughts.
Absolutely superb, my friend. I love that you touched on the management reasoning for this case. And I think that no matter what, you need to make sure that her airway is protected, um, and check a finger stick. And I think the airway dimension is especially intriguing because whenever you hear the word pain followed by altered mental status, you have to entertain the possibility of opiates being involved in that pain to AMS arc. And in those patients, the respiratory rate and therefore the airway is especially important. And I'll share my reflex thoughts. My reflex thoughts are, oh gosh, whenever there's a systemic issue going on, it's either a systemic disease or that there's something that actually connects the dots in terms of the plumbing. So whenever I hear leg, shoulder, and then brain, and that happens so quickly, I ask myself, is the common denominator the aorta? And there's an acute aortic pathology here that connects all these dots anatomically rather than systemically. And then, I think the key is not to make the mistake that you have to explain everything in one unifying diagnosis. The key is to step back and say, what are the causes of altered mental status? Let us entertain all of them. But also, in addition to that, what are the causes of altered mental status that may be influenced by the presentation of leg and shoulder pain? And leg and shoulder pain may signify a vaso-occlusive crisis in this patient. So is she having a vascular process in the brain as well? Not in lieu of hyponatremia and all that other stuff, but in addition to it. And the one very rare but important diagnosis to entertain very quickly in this patient is when she has bone pain and has altered mental status. A rare complication, but an important one to think of reflexively in this situation is what's called fat embolism syndrome. Fat embolism usually occurs in the context of a long bone fracture, but can occur as a spontaneous phenomenon in patients with sickle cell disease. So I'm right there with you, Sukriti. I think you anchored us in the practicality of it by saying, hey, this is altered mental status. Let's analyze that independently, but also to the unique issues of this case, which is that she's 50, she has sickle cell disease. And I think honestly, right now, it's all about RX before DX. So what's the status for your airway and what's the sugar before we think diagnostically? Awesome job. All right, Ravi, back to you.
Okay, so more about her past medical history, hypertension, end-stage renal disease on intermittent hemodialysis, and then medications. I don't have the information. It's not relevant at this point, but family history, social history, we'll skip over. Allergies, none. And because this was a rapid decline, getting to the vital signs, so temperature, 97, heart rate 100, blood pressure 110/70, respiratory rate 22, pulse ox 92% on room air. And her exam, pretty much unremarkable, except neurological examination, lethargic, nonverbal, minimal response to voice. And on respiratory examination, there were some crackles bilaterally, which were diffuse, and I'll stop right there.
Let's hear some Sukriti wisdom, please.
So I think that was helpful. The things that kind of stood out for me was that this patient, she has ESRD, she's on dialysis, and the way I kind of put that together with what we've talked about is Robbie mentioned, expanding on the altered mental status, and we have the missed mnemonic if this was acute, and it sounds acute or hyperacute. So when we were thinking about the hyperacute, we were thinking about things like opiates, like hypoglycemia, possible stroke. We're also thinking, well, yeah, those are the kind of things. Or this could be like post-ictal, did she have a seizure? But assuming that she's in the hospital, that this would have been witnessed. But then the other things we're also thinking about the missed mnemonic is like metabolic, and that kind of ties in well with the ESRD. So you want to know, when was her last dialysis? Usually you think of like hyperkalemia, but hyperkalemia doesn't kind of tie into altered mental status. You're thinking more things like hypercalcemia or hypocalcemia, hyponatremia, uremia would be a big one to think about in this patient. So just, I would want to know when was her last dialysis. And then the other thing that it kind of tells you is how far along. I'm assuming that the ESRD is related to the sickle cell. And so it kind of tells you how far along she is with her disease. The other things that I got from the physical exam, the bilateral crackles, they kind of clue you into volume overload, but it doesn't necessarily change how I think about this case, because in a patient with dialysis, this could be normal, some amount of volume overload. I'd be interested to see some of like the other physical exam findings, like does she have a JVD? Does she have like lower extremity edema? But kind of just putting that on the back seat for now. And then the fact that she's lethargic and nonverbal again tells us about the severity. So I don't know. Yeah, it kind of maybe pushes me more away from like metabolic etiology, because I think that maybe we would have seen more signs that would be more like she would be confused or she would not be oriented, to time, place, and person. But for her to be normal and then suddenly go to lethargic and nonverbal kind of makes me think about something like Robbie mentioned, like vascular. So we're still sort of, I think, in that whole vasculature bucket. So thinking about if there's anything wrong with the walls, or even within the blood, are we thinking like, is this a thrombus, or maybe less likely something metabolic? But that's kind of where I'm at.
I think you hit the nail on the head, honestly, especially with, I mean, the reflections on the end-stage renal disease, the reflections on the crackles were superb. But I think the most sort of like advanced thing that you did there was to say, hey, I'm really worried there's something wrong in the brain. And that is so advanced because the vast majority of people with acute altered mental status have an extra brain problem. That's no different than the vast majority of patients with kidney injury have pre-renal AKI. The problem's not in the actual organ itself. But here, I think you're teaching us this law of proportionality, which is that the depth of the encephalopathy, the deeper it is, makes it much more likely that there's an intrinsic brain problem. Now, just to be clear, somebody can have devastating encephalopathy from devastating hyponatremia, but those metabolic abnormalities are usually readily apparent. So here, we didn't expect her to be this profoundly confused this quickly. And it's no different than saying the patient's creatinine is 12. What is the probability they have pre-renal disease? As soon as the creatinine is that high, it's almost impossible for it to be pre-renal alone. And when the patient is this confused, it's much less likely for it to be a metabolic issue. And the one systemic cause that can cause a profound encephalopathy is a toxin. So I think for me here, unless there's been toxin exposure, namely opiates is the big one here to think about. I'm right there with you, Sukriti. I think we need to reframe this case as a intrinsic brain issue, with the peripheral clues being end-stage renal disease, pulmonary crackles, sickle cell disease, to help us modify that. So really, really nice job taking the rare situation of AMS being a brain problem and making that a little bit more likely in this patient. Awesome. All right, Ravi, Mike, to you.
Okay, onto the labs. White count was 11. Hemoglobin 5.6. Platelets were normal. LDH 889. And chemistry was normal. The BU creatinine was at regular baseline. She was compliant with dialysis. Glucose, that was very important. Somebody asked for, Secretary also asked, was normal. It was over 100. And I'll give you a chest x-ray, had bilateral lung infiltrates, and the CT head was unremarkable. And I'll stop right there. And the next aliquot will reveal the final diagnosis.
Ooh. Um, Oh, I see. AMKs, what is, yeah. So I think with sickle cell, I think the big thing that jumps out is the hemoglobin here is 5.6 and the LDH is 80. Okay, so the baseline is 10 to 11. So I think putting that together, seems like she's in a sickle cell crisis. I don't know the retic count, but I'm assuming the retic count would be high. And then the other thing, so with the WBCs, infections, like Robbie mentioned before, so just going through it in an organized manner, infections can also, extracranial as well as intracranial infections can cause altered mental status. They're kind of, so two ways to, so we said we already through the previous aliquots determined that an extracranial infection causing this degree of altered mental status is unlikely. When we're thinking about intracranial infections, bacterial infections is something that kind of jumps out when we're thinking about acute altered mental status. But I think the other thing that I kind of maybe with an acute meningitis or an acute meningoencephalitis, um, maybe there would have been other signs, and also the fact that I'm just trying to think about the altered mental status that she's developing within the hospital. And I think the other thing that, when you think about a new symptom that develops within the hospital, you think about it either, is this something that we did? So is it, the word is leaving me, but is it something that we caused, or is it that the syndrome has just has moved along at such a fast pace, while working up this patient, just given the whole context, I don't think this, and the patient hasn't been in the hospital long enough for this to seem like, something that we could have induced. Like when you think about altered mental status in the context of patients with alcohol, sometimes when you give glucose without giving thiamine first, that's the kind of scenario I would have thought about it. But that seems less likely. So kind of infections is still, I would say it's still on the differential, but it's lower on my differential. And then the hemoglobin we talked about, the one thing that kind of I associate with sickle cell and something being intrinsically within the brain is like moyas. I've always seen it in the context of like when a patient hasn't come acutely with that syndrome. It's always when I'm talking to a patient with sickle cell and they mentioned that they had moya in the past. But that's something like theoretically I know that can present with this. The other way that we can think about, we talked about like sickle cell, and her having sickle cell can also cause predisposed to increased risk of strokes. So, but then the fact that her CT head is unremarkable maybe makes it less likely, but in an acute case, the CT is not sensitive enough to pick that up. So that would still be very high on my differential. I would probably want an MRI. And if this were to be a stroke, the fact that she doesn't have any focal deficits doesn't necessarily pull me away from that diagnosis either. It could just depend on the territory. And then the chest X-ray with the bilateral lung infiltrates. Um, the one way I would connect that to sickle cell is like when you're thinking about acute chest syndrome. But I don't know how I would tie that into altered mental status necessarily. So I think maybe at the end of the discussion, to summarize, like a thrombotic cause is probably the highest in my differential. I want an MRI to rule out stroke. I think it would most likely be ischemic in this case, because if this was something hemorrhagic, we would probably catch it on CT. But I think that would be kind of my leading differential right now.
I completely agree with you. I think we have to prioritize that. And I think I love that you picked on the combination of that you have a patient with sickle cell disease who has a brain issue and a lung issue, and that you didn't use the negative CT to dissuade you from a brain issue. In fact, you used it as guidance as to what the brain issue might be instead of being falsely reassured by it. So I think that is absolutely superb. And, at the end of the day, you have a compelling case that sickle cell has gone berserk here. You have a worsening acute on chronic hemolytic anemia, and you have chest infrared. So this is sickle cell crisis, and this is maybe systemic vaso-occlusive crisis, invoking the rare scenario where stroke leads to altered mental status. And that happens when you have multifocal strokes. It happens in other situations too, stroke leading to AMS. You can have it in parietal strokes, thalamic strokes, brainstem strokes, but the most common way is you have a shower of emboli. So that's certainly very possible here. And I think the other sort of acute reflections are do we see the recognition of the effects of sickle cell disease on this patient's kidney, and also tracking the chronic complications on her spleen. And so is this a hyperacute invasive infection with pulmonary and brain focus, so that, of the things that occur in patients with autoinfarction of their spleen, strep pneumo, Staph aureus, Neisseria, those are things you'd want to think about. Though I think they're a little bit less likely in the absence of meningeal signs or leukocytosis or a fever. So here you would be hemming and hawing about starting this patient on broad spectrum antibiotics for sure. And I think that if I change this scenario and tell you that this is a person who is in a motor vehicle accident who breaks their right hip and 4 hours later has acute hypoxemic respiratory failure and encephalopathy, you would find many case reports compatible with fat embolism syndrome. And that's actually an important consideration in this patient, and one that would be clarified on MRI. MRI has a very unique characteristic of fat embolism. So for me, I'm right there with you. There's some sort of vascular problem. And the question is it bland thrombosis from sickle cell crisis? Or in the context of the bone pain she was having, did she infarct her bone marrow and cause fat embolism? But more practically also thinking, should we, while we culture her, get antibiotics on board? So I think for me, I need an expert in sickle cell to help me with the antibiotic decision. I don't see that very often, honestly. But I'm right there with you. I think MRI is going to be key in this patient. All right, Ravi, take us home, please.
Okay, great. Superior job. Great work, Security. I love that you didn't take the CT as the final word on the CNS effects of this patient. So you wanted MRI, so we have an MRI. But prior to this, with the patient's hyperacute deterioration, she was intubated for airway protection. The chest X-ray with a ramping up of temperatures and fevers demonstrated acute chest syndrome. So antibiotics were started for that. And the MRI, once the patient was stabilized, as many have mentioned, stabilization is key. Once a patient is stable in the ICU, we're able to take it down for MRI, and it demonstrated a right transverse venous sinus thrombosis, an extensive supra and infratentorial hemorrhages consistent with fat emboli syndrome. And then a transthoracic echocardiogram with bubble study was performed. It was negative for a shunt. And then patient was treated with medical management, exchange transfusion with subsequent improvement and extubation, and mental status went back to baseline. So this was a case of fat emboli syndrome, as Rabi had got off right from the start. And it's very interesting. I've never seen this before. And like Rabi had mentioned, you usually see this with trauma in orthopedics, motor vehicle accidents. And usually do see with this patient, there was a very acute deterioration with initial presentation for sickle cell crisis with acute chest syndrome. And then the mental status changes just occurred suddenly in the emergency room. And the usual etiology of fat emboli is due to vaso-occlusive bone marrow necrosis, which releases fat emboli into the venous circulation, and then it's free to manifest anywhere. And the diagnosis is key via MRI findings. Typical findings usually will be those perivascular microhemorrhages, multiple microinfarcts, and presence of fat globules within the microvasculature. So it's something to think about. Like I love that you took Miss Mnemonic and then brought a sickle cell crisis on top of that to then further focus in on what could be going on with this patient. So great job.
Ravi, I love that when we asked you behind the scenes, oh, does anyone have a case? You're like, oh yeah, maybe I have a case, and it's a case of fat embolism syndrome from sickle cell, like an NAGM case. So thank you for keeping that in your back pocket. It was a real treat, real treat. So Kriti, how do you feel now?
Before I say that, I think that this was so much fun. Ravi, thank you for sharing such a great case. And I'm always amazed by Ravi whenever he discusses or whenever I hear him on the podcast. But I think you made me feel so comfortable while discussing. It was just like discussing with a friend. And I told Ravi and Reza, like during night float, I was on night float recently, and when we had like a quiet night, I didn't really know what to do, and there aren't too many people in the hospital. So I would listen to Ravi and Reza, and it would just feel like I had like two friends who are on night float with me. So it's always so great to hang out with you guys.
Oh, so Kriti, I'm so glad that I get to sneak in and reflect after you do, because while I appreciate that tremendously, I really do. I think for me, you've discussed many times on VMR before, but it has been a while since I've heard you, and you're putting in a tremendous amount of work into your clinical reasoning and your teaching skills and just how you articulate your thinking. And I was kind of sitting back, I'm like, oh my gosh, like I met her 2 years ago, and I remember her discussion was excellent then, but watching you do what you did today is unreal, and the growth is unreal. And it's mostly navigating tense situations where you could so easily be misled. It's not so much it's not so much your medical knowledge, it's deploying facts that allow you not to go down the wrong door. And there are so many wrong doors here. The end-stage renal disease was a distractor. The hypertension, the mild leukocytosis, like all those were distractors. But the most powerful thing in your reasoning was how you refused to decline an intra-brain problem despite so many reasons not to. And that is very commendable. I hope we get to do this again whenever you have a little bit of a break. I certainly will savor this one. And thank you, Ravi, for making it happen. All right, Yasmin, take us home, please.
Oh, of course, I am right here, like again, for another teaching point. Amazing case. Thank you so much for this. So we start evaluating missed mnemotechniques in this acute subacute setting for a patient with AMS. And for this patient with sickle cell disease, we started thinking about AMS plus bone pain. Maybe it was fat embolism from the very first aliquots. They can occur spontaneously in sickle cell disease. And we started thinking, well, Dr. Ravi started thinking about looking at an MRI and making a diagnostic differential with the vascular process. Fat embolism has a classic triad of hypoxia, neurological symptoms, and petechial rash, although we didn't see that in this patient. We also thought about dialysis complications, which can be metabolic disturbances, infections, protein loss, abdominal hernias, leakage of dialysate, and pleural effusions. About this, we were thinking, well, it could be a metabolic disturbance. That's why buildup of a toxin could be causing these neurological issues in this patient. Treatment for sickle cell crisis, consider blood transfusion and adequate supplement treatment with hydration, pain management, nasal oxygen, and thromboembolic prophylaxis. Dr. Ravi has said in the chat that they used opioid for crisis in this patient. And also, patients with sickle cell disease can have functional asplenia, which equals to an increased risk for encapsulated bacteria. And in this final diagnosis, that was the fat embolism syndrome, and sickle cell disease context, bone marrow necrosis due to microvascular occlusion and sickle cell crisis increases the risk of this. And finally, in the MRI, we found a right transverse venous sinus thrombosis and extensive supra and infratentorial microthrombosis, as well as perivascular hemorrhages. So this is all for the teaching points for today. And thank you again for this amazing case, Dr. Ravi, and amazing discussions.
Superb. Thank you for that great recap in such a nice narrative way. All right, y'all. We'll see you all tomorrow for our and thank you again, everyone. Bye.